We've seen 3 great cases. Before we vote, are there any questions from the audience? Anybody want to pose a question? There's a microphone right there. John, do you have any?
Well, perhaps it's the same question to all 3. Is with your very first experience of using IVL, did it do what you were hoping it was going to do? Perhaps you could just tell us about the very first time.
I guess I'll start it off. My mic working? Yeah. All right, let's try this one. You know, it's really nice when you have a technology that you understand the theory behind it, and then it actually translates into an equivalent outcome or even better outcome than you had hoped or anticipated. And that was certainly our experience with this technology. And we've now been fortunate enough to have it for about 2 years. And I mean, we've literally done hundreds of cases with IVL, and it really lives up to the hype. It's just so great to have a way of dealing with calcium without having to worry about distal embolization or perforation. And particularly for critical limb ischemia patients, that is incredibly invaluable. It's quick, it's simple, and it really works. And I just don't know any other technology that can really make that claim.
So that actually was my first IVL case ever. And I didn't expect it to work. You're kind of like, well, we'll give this a shot. And then as you go farther in your experience, I think you'll be pleasantly surprised. And there's a saying, you know, simplicity is the ultimate sophistication. So really, I think that you'll come up against some of the most difficult cases, which you've seen some pretty good examples of here, and it working very, very efficaciously and safely, I think is the key point.
Yeah, I concur with both of the co-panelists. I mean, it's one of those technologies where when you sit back, you're like, the ease of use. You cross a lesion with a wire. If you get the balloon across, you know the case is over. You're going to remove that calcium. You're going to have no embolization, very few dissections, and you're going to be able to facilitate the advancement of either a TAVR catheter or any large bore sheath or impella. So this was also my very first case, and I'll tell you, I am extremely impressed, and hope we can help a lot of patients in the future. Thanks.
Okay, look, thank you. Any more questions? Any question, please?
I'll just ask, with reference to coronary work particularly, the last statement that you made was if you can cross. So my question is, the ability to cross the lesion, particularly in coronary work, what percentage roughly do you think will still need to be using rotational atherectomy or other devices to deliver?
It's a very good question. I think, well, I'm going to present some of the data from Disrupt CAD 1 and 2, and there's the presentation from this afternoon. There haven't been crossing failures in the trials, but in the real world experience, yes, there have been some. And there's now a combination of experience with rotational atherectomy and shockwave in a small percentage of cases where you can't cross. But there are crossing solutions, I think, in the pipeline. So I think it's rapidly evolving, and I think we may have a crossing solution as well soon. So
That's excellent. So
can we vote?
you can vote. This summarizes each of the cases. And Suzanne, since we got off a little bit in time, I'll just go ahead then while they're voting. Do you want to talk about expanding applications? You guys, I don't think need. You text Shockwave to 22333 and then text in the number of your winner.
You can't vote for yourself, guys. Come on.